My name is Heather Leitch. I'm from St. Paul's Hospital in Vancouver, Canada, and I am pleased to talk to you about promising treatment advances for MDS and AML updates from EHA 2021. Here are my disclosures. One of the big problems in MDS for, all risk groups is transfusion dependence, which not only impacts quality of life, but also impacts survival. As you can see, the survival decreases by increasing transfusion need, but also leukemia-free survival as well. We do have updated data from the European Leukemia Net MDS registry also showing that those with no transfusions fare best and those with high transfusions fare worst. One of the problems with transfusions is iron overload, which has its own set of toxicities and which I'm going to come back to at the end of this presentation. So we have what looks like a reasonably long list of treatment options for MDS. However, for the majority of patients, these are much more limited. In lower risk, erythropoiesis stimulating agents and supportive care, and higher risk hypomethylating agents with or without other agents. And so we really need new treatment options. There's actually quite a bit of information from this year's European Hematology Association. So I'm going to try to get through an ambitious amount. I have grayed out areas where I think it's more information than you guys need, but I want to remember it. And I'm going to start with MDS biology, lower risk and higher risk MDS, and I'm going to go quite briskly. In higher risk MDS, I am going to include some data on AML and then talk about some iron data. So in terms of MDS biology, there's a lot of information recently that inflammation plays a key role. We're also going to talk about some mutations and stromal cells as a potential therapy. So the first one is concurrent mutations in ZRSR2 and TET2 disrupt myeloid and erythroid differentiation, cause abnormalities compatible with MDS in mice. It was an oral presentation. The background is that splicing factor and epigenetic gene mutations are the most frequent genetic alterations found in MDS, and about a quarter of patients have concurrent mutations in these pathways, suggesting a cooperative role in MDS pathogenesis. Inactivating mutations of the minor spliceosome factor ZRSR2 and alterations in the epigenetic regulator TET2 are frequently found together and associated with higher blast percent in the bone marrow, AML transformation risk, and shorter overall survival. So the underlying molecular mechanism of disease is at this point unclear. So this is what happens with translations. This is in your cells. So DNA has the genetic code. It's transcribed to pre-messenger RNA, which consists of exons or coding sequences and introns or non-coding sequences. It's then processed to messenger RNA, exported to the cytoplasm and translated to proteins. This is the spliceosome, helping to take out the introns, resulting in the mature messenger RNA. And this depicts DNA wound around histones, which are proteins that protect it. It also shows methyl groups, which inactivate the genes that they're adjacent to, and acetyl groups are important as well. And we refer to the methyl groups and acetyl groups as epigenetics. So they wanted to investigate the role of Z and ZT mutations in hematopoiesis and MDS. They generated a Z mutant mouse model and a ZT double mutant model as well. And they looked at hematopoietic stem progenitor cell functionality using bone marrow transplantation and colony-forming unit assays. And they did whole transcriptome sequencing of leukemia cells to look at gene expression and identify changes in splicing patterns. This is what's meant by CFU assays. So what you do is you put mononuclear cells, which contain the progenitor cells, in a semi-solid medium in a little plate, and the mature cells die off and the immature cells grow up to form colonies. So this is what's called a colony-forming unit erythroid. This is a burst-forming unit erythroid, which is a little more immature, and you can tell by the number of cells it gives rise to. Then we have a CFU granulocyte macrophage and a CFU GM with also erythrocytes and megakaryocytes. So in ZT mice, immunophenotyping, looking for cell surface expression, indicated a global alteration of hematopoiesis, including all these points that I've grayed out and summarized as immature cells increased and mature cells decreased. And CFU assays confirmed a significant increase in myeloid and erythroid progenitors in these mice. A third of them showed anemia and thrombocytopenia, and the peripheral blood cells showed dysplastic features. Transplantation experiments indicated impairment of Z cell capacity to repopulate the recipient bone marrow, and conversely, the double mutants showed enhanced engraftment capacity. RNA sequence analysis from the double mutants revealed 3,000 differentially expressed genes and 43,000 differential alternative splicing events compared to controls. So that could certainly mess up your RNA and your proteins. Exon skipping, or skipping of coding sequences, was the most common alternative splicing event. And they concluded that co-occurring mutations in ZT disturb myeloid hematopoiesis and cause abnormal myeloid and erythroid differentiation. A third of the mice displayed some MDS-like abnormalities, and transcriptome analysis revealed an important dysregulation in gene expression accompanied by aberrant mRNA splicing. And this provides new insights into the biology of this MDS subtype and opens the possibility to more in-depth interrogate its molecular disease mechanism, which could potentially lead to new treatments. The second abstract is TET2 mutations in MDS. The same mutation disrupts natural killer cell biology. So one of the reasons that we're not all forming tumors all the time is that we have what's called immune surveillance. And so immune cells patrol the body and sort of nip tumors in the bud. So the background is the majority of MDS patients harbor somatic mutations, including in genes encoding for epigenetic regulators, as we heard, in TET2, in this case also IDH1 and 2. And these mutations have also been found in CHIP, which is a pre-leukemic state, but the mechanisms of disease progression remain largely unknown and may implicate defects in anti-leukemic immunosurveillance. So here we have macrophages, T cells, engineered CAR T cells, B cells with their antibodies, dendritic cells, and natural killer cells doing the immune surveillance and getting rid of early tumors. So natural killer cells are sort of a more primitive form of immunity. Among immune cells, NK cells are key players in eliminating tumor cells, with a diagnosis of AML and MDS, they showed impaired NK cell phenotype and functionality. However, there were no data on the impact of NK cell mutation status in MDS patients at diagnosis. So they looked at samples from 63 patients with MDS prior to any treatment and did next generation sequencing using an 80 gene panel on sorted NK and T cells. So this shows how they sort cells using cell surface markers. And they found that the phenotype of NK cells in the blood and bone marrow of MDS showed a strong reduction in what's called the KIR2D expression, counterbalanced by the increase of this other marker at the NK cell surface in patients harboring TET2 or IDH mutations. NGS analysis revealed a shared mutation profile between blasts and NK cells. KIR expression correlated with the variable allele frequency or the level of TET2 mutations in NK cells, and chromatin immunoprecipitation experiments in primary NK cells unveiled direct binding of TET2 on the KIR promoter region in the DNA, which is something that allows transcription to occur. DNA hypermethylation of the KIR locus and other genes involved in NK cell physiology was seen in the mutant cells. And importantly, treating the NK cells with hypomethylating agents in vitro restored the cell surface expression of this antigen. So they concluded that they showed mutations in TET2 altered NK cell biology and highlight the potential dual role of mutations in the emergence of MDS and also immune defects, which could lead to AML progression by associating oncogenic mechanisms and tumor escape from immunosurveillance. The third abstract is using tissue microarray to detect inflammasome signaling components that contribute to the pathogenesis of MDS. So the background is that pathogenesis is multifactorial and potentially linked to constitutive innate immune stimulation converging on what's called the NLRP3 inflammasome to induce pyroptosis, which is a form of programmed cell death. Inflammasome assembly is initiated by both cell extrinsic and intrinsic stimuli, resulting in cell death and proliferation, leading to maturation and differentiation blocks. So this depicts the inflammasome, signals leading to it, and signals emerging from it, leading to cell death. So they wanted to determine whether immunohistochemistry, another way to look at cell surface markers, could be utilized to assess expression of inflammasome components. And they looked at 43 low-risk MDS patients and did a tissue microarray using MDS bone marrow, and immunohistochemistry was done for inflammasome component expression. This shows a correlation between certain inflammasome components. They did find that the IHC expression of these antigens did not correlate with WHO MDS subclassification, IPSS, IPSS-R score, disease progression, or survival. And they concluded that IHC staining of inflammasome activators using tissue microarray may allow better characterization of molecular pathways contributing to MDS pathogenesis, and did see a correlation between expression of antigens known to be increased downstream of the inflammasome activation, and did find that this particular marker correlated with blast count in the bone marrow. In the future, they want to compare expression patterns between normal, low-risk, and high-risk MDS and correlate findings with clinical outcome data to further elucidate pathogenesis of MDS and identify potential targets for treatment. This abstract is activation of distinct inflammatory pathways is driven by genetics. It's from UV Platzbecker's group. MDS lie on a continuum of myeloid neoplastic progression between CHIP and myeloid leukemia. Immune signaling in the marrow has been identified as a determinant of progression, suggesting it may be possible to prevent or delay progression by targeted anti-inflammatory therapy. However, as little is known about the extent or functional relevance of patient-specific variations in inflammatory network pathways. So they wanted to look at this both in lower risk as well as non-CHIP, CHIP, high-risk MDS and CML patients, and associate this with phenotype, genotype, and outcomes. They looked at 102 bone marrow samples and did arrays for expression of these 12 genes that I've grayed out, encoding inflammasome-related proteins, and also looked at 14 circulating inflammatory mediators, and then correlated with mutation status and clinical parameters. Inflammasome gene expression was higher in lower risk MDS than in either CHIP or high risk MDS. In lower risk, samples selected inflammatory biomarkers were differentially expressed and correlated, indicating the presence of distinct patterns of inflammation. A principal component analysis, which is a way of taking a lot of data and compressing it to smaller amounts that are digestible, identified consistent subgroups in gene expression, separating lower risk MDS into 3 defined clusters, and re-examination for the inflammasome-related gene expression confirmed these 3 clusters. So cluster 1 associated with the presence of SF3B1 mutation or ring sideroblast, hypercellular marrow, transfusion dependence, and expanded erythropoiesis, as well as altered IL-1 beta expression. Cluster 2 associated with del5Q, hypocellular marrow, and transfusion independence, as well as high IL-1 beta. Cluster 3 associated with fewer mutations, hypocellular marrow, and expanded erythropoiesis, as well as high IL-1 beta. And they also show differences in IL-18. And so this figure just shows you in pictorial form that there are 3 different clusters. So they demonstrated the presence of distinct inflammasome activation states on lower risk MDS of potential relevance for patient stratification to anti-inflammatory therapies. And they're looking at gene expression in sorted cell populations to further increase the resolution of the analysis, which will be validated in the prospective CANFIRE trial investigating the IL-1 beta antibody canakinumab in lower risk MDS. And this is my addition that up to a third of MDS patients have related autoimmune phenomena, so inflammation seems to be important in MDS. In terms of treatments, this is from UV Platzbecker, and he said it's getting complex. And so I've circled some of the treatments that we're going to talk about and where they act on the cell, as well as adding the stromal cells. And so the first abstract is mesenchymal stromal cells as a potential therapeutic tool in enhancing residual healthy hematopoiesis in low-risk MDS. It was a poster presentation. The stromal cells are cells of the bone marrow microenvironment. They support maturation development of the hematopoietic cells. They're abnormal and characterized by poor hematopoietic support, and dysfunction contributes to expansion of the malignant clone. They wanted to see whether healthy MSC might have therapeutic potential in terms of encouraging the residual healthy hematopoiesis to occur in MDS. So they looked at bone marrow samples from MDS patients who were not treated, and also from healthy donors, and looked at mononuclear cells which harbor the progenitor and stem cells, and also the mesenchymal stem cells. They did short-term co-culture experiments, adding MNC to MSC with different combinations of healthy and MDS cells. And they found in a basal state without co-culture with MSC, MDS mononuclear cells showed deficient formation of CFUE and CFUGM, as well as imbalance between the number of CFU and clusters, which translates to defective hematopoiesis. And they also wanted to determine the effect of addition of MSC on mononuclear cells of MDS patients. And so looked at the ratios of these. And you can see from the pictorial graph that I won't go into details, but there are differences. And what they found was that the addition of healthy donor MSC trended to increase erythroid colony formation, and GM were significantly enhanced by addition of these cells. And in an environment simulating the disease condition where they had mixed MDS and healthy donor MNC, so residual hematopoiesis, a significant recovery of hematopoietic capacity occurred with the addition of the mesenchymal cells, which was greater if they were from healthy donors. So taken together, the results suggested that healthy donor MSC enhances MNC clonogenic capacity, especially when co-cultured with mixed MDS and healthy donor. And this is the situation that occurs in lower risk MDS patients where normal and MDS hematopoiesis coexist. So they think this could be a potential therapy in the future. Turning to lower risk MDS, first talking about luspatercept, which acts here on the cell. It's an erythroid maturation agent, which has been studied in lower risk MDS with ring sideroblast or SF3B1 mutation, and caused many patients to become transfusion independent for a period of time. So they defined low transfusion burden and high transfusion burden, and showed and also looked at mean cumulative number of red cell units, and found that this was 6 in luspatercept patients versus 13 in placebo patients. In the low transfusion burden patients, in high transfusion burden, the numbers were 17 versus 24. And they found that the cumulative transfusion visit in low burden patients was 4 versus sorry, it's behind my little picture. I think it was 8. And for high burden patients was 9 versus 12. Luspatercept responders continued to show additional reduction in transfusion units and visits beyond 24 weeks through 144 weeks relative to non-responders. So they concluded that in the Medalist trial, luspatercept reduced cumulative units and visits compared to placebo over the first 24-week period, and regardless of their baseline transfusion burden level, and that responders continued to respond beyond 24 weeks. And so this shows in low transfusion burden the number of units with luspatercept and placebo patients, and in high transfusion burden patients. And this also shows the difference in luspatercept responders in pink and non-responders in green, in low transfusion burden and in high. The second one is efficacy of imetelstat, independent of molecular subtypes in heavily transfused non-delta 5q lower risk MDS, relapse or refractory to erythropoiesis stimulating agents. And so this acts here. I've included a picture of a chromosome. The telomeres are the ends of the chromosomes, which the length is important for allowing the cells to grow and divide. And so in an early phase trial, this did show efficacy in terms of inducing transfusion independence in these patients with durability and a manageable safety profile. So they wanted to look at the efficacy in molecularly defined subtypes based on cytogenetic and mutation profiles. And they did find that 90% of patients had at least one mutation, among whom a lot of them were SF3B1, and 50%, 28%, and 17% had 2, 3, and greater than 3 mutations. The 8-week transfusion independence rate was 60, 50, and 20%, and similarly decreased in those with, in terms of the 1-year rate, in those with more mutations, as well as the erythroid response rates. However, responses were seen in all groups. The most frequently mutated gene was SF3B1. The other genes all coexisted with the SF3B1, and they identified hotspot mutations within SF3B1 and found durable transfusion independence in all patients with hotspot mutations except this particular K666R mutation. They also looked at the function of the mutations, and they had different functions, including splicing function, epigenetic regulation, or receptor kinases, and did find efficacy in all these groups. So they concluded that imetelstat demonstrated clinical efficacy across different molecular defined subgroups, and there is a phase 3 trial that's ongoing, and this just shows the results in pictorial form. Turning to higher risk and starting with first-line treatment, there are a number of agents being combined with hypomethylating agents in first line. This is venetoclax in combination with azacitidine for treatment of patients with treatment-naive, higher-risk MDS, phase 1b results. And so here is where azacitidine works. It's on the DNA. Here is where venetoclax works. I've shown you a close-up. So what venetoclax does is it opposes the function of BCL2, which in turn opposes programmed cell death. So venetoclax restores the ability of the cell to die off the way that it should. So HMA, as you know, are the standard of care for patients with higher risk MDS not eligible for allogeneic stem cell transplant. However, the overall response rates are suboptimal, and their expected median overall survival is less than 2 years. They added venetoclax, which has shown efficacy. So they enrolled higher risk MDS patients with blasts less than 20%, so not AML, reasonable performance status. Venetoclax is given daily, and looked at safety, overall response rate, and overall survival, and looked at baseline mutational status. So the median follow-up was 23 months. All patients had at least one side effect. The most common were cytopenias and GI side effects. 30-day mortality was reassuringly low at 1%. The intention to treat overall response rate was 80%. And the median time to complete response, importantly, was 2.6 months, which is much shorter than AZA alone. And this obviously allows patients to be well with quality of life for longer. The response duration was 13.8 months. The transfusion independence rate was 46%. Median overall survival, 28 months. 23% moved on to post-study allogeneic transplant. And so they concluded that the combination was associated with rapid and durable response, promising efficacy, including remission rates and overall survival, and acceptable safety profile. This looks at the same combination in AML, and what this one slide shows is that if you suppress the residual disease more, then you get longer duration of response overall and event-free survival than if there's less suppression. This is lower residual mutation load following treatment with pevonedistat and azacitidine versus AZA alone. And so this is where azacitidine works again. Pevonedistat is a metallation inhibitor, and this results in alterations in proteins being degraded by the proteasome, which is kind of the garbage disposal of the cell. So this did show promising efficacy in early phase trials. And this study showed showed fewer treatment emergent mutations in the combination arm. However, news just last week showed that a phase 3 trial failed to meet its endpoint, and so development of this agent has been suspended, and I won't talk about it further, except to say that this is obviously disappointing, but it's why we do phase 3 trials. We want to be sure it's effective and not expose people to something that's not effective. This is sabatolimab combined with hypomethylating agents in high-risk MDS and AML. And so again, azacitidine, sabatolimab is over here under my picture. It's an antibody that works on TIM3, which is expressed in the picture below, both on T cells or NK cells, but also on myeloid leukemia cells. So this is the background, what I just said, and early phase studies showed promising efficacy with good safety. So they also treated treatment-naive patients and randomized them between hypomethylating agent plus or minus sabatolimab. They saw dose interruptions, dose reductions, and discontinuations in some patients, but not so many. Found that responses were independent of bone marrow blast burden, and remission rates were similar in patients who were over 75 years and younger, with 83%, 86% response durability, and up to 80%, 88% in AML after 6 months. In patients with TP53 mutation, which portends adverse prognosis, or with other mutations conferring high risk, remission rates were also seen that were quite reasonable at up to 60% in both MDS and AML, and even in patients with a complex karyotype, which is also poor risk. Biomarker analysis identified IL-1 beta, again, that inflammation theme, as one of the most differentially expressed genes in the bone marrow of responders versus non-responders, and single-cell RNA sequencing showed that combination down-regulated IL-1 beta in blast cells, but consistent with prior observations in TIM3 deficient patients, it upregulated this in myeloid cells. So they concluded that SABA and HMA showed favorable tolerability in MDS AML, including in patients with severe cytopenias at baseline, and promising remission rates were seen irrespective of baseline blast burden and in older patients and patients with adverse risk mutation. This one is all trans retinoic acid enhances the cytotoxic effect of D-cytobine on myelodysplastic syndromes via activating the RA or alpha NRF2 complex. So all trans retinoic acid acts on the retinoic acid receptor alpha and forces differentiation of myeloid cells. So we know decitabine is a first-line treatment. However, the clinical outcomes are not good enough. So they wanted to investigate the efficacy of the combination. And so this was first-line treatment for MDS and AML cells. They found that this was not for patients, this was for cell lines, and it synergistically induced apoptosis of MDS cell lines and inhibited viability of primary cells from MDS and AML patients who were untreated. Combination treatment significantly decreased leukemia burden, prolonged survival in a mouse model, and it activated the nuclear factor erythroid 2 related factor, which is interesting, at least to me, because it is a factor that alters redox activity in the cell or oxidative stress, which can be involved in iron toxicity as well. And so they found that cytotoxicity was ROS-dependent reactive oxygen species. Co-treatment promoted ROS accumulation, enhanced ROS-dependent cytotoxicity, overcoming resistance of MDS cells to decitabine, which is exciting. So they concluded the combination exerts collaborative cytotoxicity in MDS cells, and the combination higher-risk MDS holds potential for clinical application, deserves further development. And this is just a graph of the survival of the mice, which you can see in blue is better in the combination arm. So what about second-line treatment? This is a combination of guadocytabine, the oral form of decitabine, with atezolizumab, an antibody in patients with relapsed refractory MDS or CMML. And so there's azacitidine again, and here's where the antibody works. And in the picture below, I've shown the PD-L1, PD-1 pathway. And so the background is that after failure of hypomethylating agents, the median overall survival is only 5 to 6 months, which isn't good enough. And although multiple combinations of newer agents with AZA in first line are being trialed, as I've shown you, treatment options for second line are limited. So there are preclinical and clinical data suggesting that myeloblasts express PD-L1 and that HMAs induce T-cell PD-1 expression, which is the receptor for this, which may promote resistance or relapse despite effective hypomethylation. So they looked at safety and efficacy of the combination after HMA failure, and a phase 1/2 clinical trial with relapsed refractory higher risk MDS or CMML after failure of HMA. Their primary endpoint was overall response rate, and they enrolled 33 patients and found that the most common toxicities were cytopenias, not surprisingly. There were some autoimmune events that were attributed to the antibody. 11 patients came off treatment for different reasons. A median of 5 cycles was administered, median follow-up of 25 months, 4 patients still on treatment. Overall response rate of 30%, which is not bad in a refractory setting. Median overall survival 15.1 months among treated patients, and progression-free survival of 10.5 months. This just shows the progression-free survival of MDS and CMML. So they concluded in this early phase trial with higher risk, predominantly HMA refractory MDS, quatocytidine with atezolizumab yielded modest WG responses. However, overall survival appeared better than predicted for this patient population, and they're doing ongoing correlative work to investigate the immunologic characteristics of the long-term survivors. A second abstract was eltanexor for the treatment of patients with refractory and relapsed MDS. So hypomethylating agents, eltanexor, it's a SINE compound, which is a selective inhibitor of nuclear export. So in other words, it stops things from being exported from the nucleus to the cytoplasm. And an early phase study showed some efficacy with few side effects. So they wanted to do a subgroup analysis and update overall survival on the population. It was a single agent treatment, and 15 patients were evaluable for efficacy, and they had median 2 prior treatment regimens, so pretty refractory disease. The marrow CR rate was 35%, and 25% has stable disease for a total disease control rate of 60%. And patients with disease control, not surprisingly, had longer overall survival than with progressive disease, 9 months versus 3 months. They concluded that single agent oral eltanexor was active in patients with refractory MDS, and those with marrow complete response had longer overall survival, and that further evaluation of this medication is warranted. Turning to iron for my last couple of minutes, this is my area of particular interest. So the rectangle depicts transferrin, which is a protein that carries iron in the blood and inactivates its toxicity. However, there's lots of iron in transfused blood. So once transferrin is saturated, we see the appearance of non-transferrin bound iron in the plasma, which can not only directly deposit into the tissues and organs, including the bone marrow, but because of the ability of iron to transfer electrons, can undergo a chemical reaction leading to the production of oxygen-free radicals, or ROS. And these have been shown in multiple studies to damage lipids, proteins, and nucleic acids, which could have consequences for the cells, including cell death and also malignant progression from mutations induced by the ROS. We do have clinical information that oxidative stress is important in MDS. This is an analysis from the European Leukemia and MDS regimen looking at labeled plasma iron, which is a subset of non-transferrin bound iron. They found the best survival was in patients who were transfusion independent and had undetectable LPI. The worst was in those with detectable LPI who were transfusion dependent, and the other groups fell in between. So, unfortunately, labeled plasma iron is difficult to measure in clinical laboratories and is not standardized between clinical laboratories. However, we do know that at a transferrin saturation over 80%, we see the appearance of labeled plasma iron. So, we turn to the Canadian MDS-CAN registry to take a look at our patients, their transferrin saturations, and whether that correlated with clinical outcomes. And this was quarterbacked by Jennifer Teichman, who's an MDS fellow at the Sunnybrook Hospital in Toronto. We do know that iron overload measured by increased ferritin level is associated with increased mortality. However, ferritin is influenced by a number of factors, including inflammation, which we've heard can be a factor in MDS, and maybe not the best measure of iron overload. So as I showed you, transferrin saturation correlates with the presence of oxidative stress. So we looked at TSAT in our MDS patients, its relation to ferritin level and clinical outcomes, and looked at transfusion density as well. The TSAT categories are shown here, as were ferritin categories. There were 718 patients with a median age of 74 years, so pretty average for an MDS population. TSAT and ferritin were only moderately correlated over time. However, in transfusion-dependent patients, there was a significant increase in TSAT over time, not surprisingly. Higher TSAT and ferritin were both associated with inferior 5-year overall survival, progression-free, and leukemia-free survival. And in multivariate analysis, TSAT over 80% and high transfusion density were significant for overall survival. So here's the overall survival curve, and you can see that those with a transferrin saturation over 80%, which indicates the presence of oxidative stress, has significantly worse survival, and importantly, also worse cardiac death-free survival. Why is that important? So we concluded that among predominantly low to intermediate risk MDS patients, TSAT correlated modestly with serum ferritin. However, TSAT over 80%, ferritin over 800, and high transfusion density were all associated with inferior survival, and that may be an indicator of the degree of oxidative stress and is readily measurable in a clinical setting, which is the important point here. And also the relationship between elevated TSAT and reduced cardiac disease-free survival warrants further study. Why is this important? So this graph is one of several studies that shows that cardiac disease is a leading cause of death, non-leukemic death in MDS patients. So the salmon is deaths from MDS and AML, and of the non-leukemic deaths, cardiac deaths are the biggest slice of the pie. Could this be from increased oxidative stress? We also showed in our patients from Vancouver, we looked at cardiac events and found that those receiving iron chelation therapy, which basically neutralizes free iron, had a longer time to first cardiac event than did those who are not receiving iron chelation therapy. So some of these data are summarized in updated Canadian guidelines for the management of iron overload. And we took these guidelines and translated them into an online interactive algorithm called the MDS Iron Road, which is available in English and French. This is the overall algorithm. There's also a step-by-step way to walk through. There's links to information on all steps along the way. There's level of evidence and grades of recommendation, as well as all the references. And if you walk a patient through, it takes you to a treatment recommendation. So if you put mdsironroad.org in the top part of your browser, the username is Iron Road without a space, and the password is Make Iron Great Again without spaces. So to summarize, progress is being made in elucidating the cellular and molecular pathogenesis of MDS, which may translate in the future to better treatments. Transfusions impact negatively on clinical outcomes, and treatments aim to reduce transfusion requirements and extend survival. There aren't enough treatment options for lower risk MDS. There really aren't enough for higher risk MDS. Several agents show promise in higher risk MDS combined with HMA in first line, and there really aren't enough options for higher risk MDS in second line. However, there's a couple of the newer treatment options that do show some promise. Control of iron overload in MDS is important in optimizing outcomes. For MDS in general, go to our other website, which is mdsclearpaths.org. And for iron overload, go to MDS Iron Road. And so I'm going to stop with something I borrowed from the Thalassemia International Federation, which is keep calm and chelate, or I would translate that into keep calm and reduce transfusion requirements. And that's my last slide. There's a picture of Vancouver. Happy to take any questions now or in the future. Thanks for your attention.
Hello, everyone. It's my pleasure to be with you today via this Zoom internet meeting. And I've been tasked to discuss the role of allogeneic transplantation in myelodysplastic syndrome. This is my title slide. As you can see, I'm from Seattle. And here is the Fred Hutchinson Cancer Research Center. And then we have the University of Washington Medical Center. This is the synopsis. I'll begin with a review of stem cell transplant. I'll talk about how we find a donor and some exciting new data indicating that there are potentially different donor options available for patients. We'll talk about how age impacts transplant outcomes, when MDS patients should be considered for transplant, should they receive treatment before their transplant, and then we'll end with how conditioning intensity or how we prepare patients for transplant affects outcomes. So by way of review, HLA typing has nothing to do with blood type. Your HLA type is actually on a completely different part of your genetic code. It's present on chromosome 6, whereas your blood type is carried on chromosome 9. You get half of your immune system from your dad, and you get half of your immune system from your mom. So with each potential sibling, there's a 25% chance that they could match you. And if you don't have a sibling match, we can frequently identify an unrelated donor that also matches you. It would be best to find matched donors when possible. Transplantation is the only potential cure for MDS. And what it involves is giving either chemotherapy or radiation to prepare the body to receive the donor cells. And the donor cells can be infused and collected either from the peripheral blood or from the bone marrow. But when we infuse the donor cells into a patient, we actually infuse them through what we call a central intravenous line. There's basically two different ways to prepare a patient to receive donor cells. One way is to give them very high doses of chemotherapy or radiation. That's called myeloablative conditioning. Another way is to give them lower intensity types of conditioning regimen. That's called a reduced intensity conditioning regimen. We tend to give myeloablative conditioning to younger patients, less than age 65, for instance, and patients who have good health. And we tend to give reduced intensity conditioning to older patients over age 65, or if they have some underlying health problems. Historically, we thought that transplantation really only worked through the conditioning regimen itself. And that was the more intensive a regimen you give, the more likely you are to cure the cancer. But we now know that stem cell transplants actually also work in an additional way. And that additional way is that the immune system of the donor can actually attack the cancer cells. And that is called a graft versus leukemia effect. So as I said, that's when the donor's immune system attacks your cancer cell. Now, on the other side of that, the donor's immune system can actually attack the host body. We call that graft versus host disease. So one of the issues that we have to deal with frequently in the post-transplant setting is how do we balance this graft versus leukemia effect with graft versus host disease? And this is something that we continuously struggle with, because graft versus leukemia is a good thing, but graft versus host disease is a bad thing. So if we could separate this out, where we have lots of graft versus leukemia, but not very much graft versus host disease, that would be ideal. When we talk about the conditioning intensity, there are very intensive regimens that are more toxic, but also have less relapse. And there's very low intensity regimens that are less toxic, but also have a higher rate of contribution of this graft versus leukemia, and because of that, higher relapse rates. So when we see an individual patient we're always trying to select what is the ideal conditioning intensity regimen for that given patient. All right, now I'd like to spend a few minutes talking about donor selection. And there was a pivotal randomized trial that explored different types of donors for patients who had acute leukemia or lymphoma. It was a wide age range, and it was done at multiple different centers through a transplant group, transplant research group that we call the BMT-CTN. And this was meant for patients who had no matched sibling donors and had no matched unrelated donors. And they were randomized to either receive umbilical cord blood or haploidentical bone marrow. Now, haploidentical bone marrow is someone who's half matched to you. So that's generally a brother or sister or a parent or even a child, but they don't have all of your same immune system. They have half of your immune system. So that's called a haplotransplant. And then umbilical cord blood are cells that are actually collected from the umbilical cord and from the placenta after a baby is born. Umbilical cord blood was thought to have what we call stem cell plasticity. Because it serves as an immunologic barrier between the mom and the child, it has properties where it's easily adaptable to new immune systems. So it was thought that this would be good, and that you could have patients who receive umbilical cord blood stem cells that are highly mismatched, because umbilical cord blood stem cells are more adaptable. So this study was done to answer the question, is it better to have someone who's half matched to you, or is it better to have an umbilical cord blood donor? If you look at the relapse incidence between the patients who received an umbilical cord blood transplant or a haplo bone marrow transplant, it was really identical over the time of this study. When you look at the overall survival, however, the survival was better for patients who received a haploidentical transplant compared to umbilical cord blood transplant. And that was primarily due to higher problems with infection and treatment-related mortality in the patients who received umbilical cord blood. So I would say that on the basis of this study, many people have moved away from umbilical cord blood and instead doing haplotransplantation. It hasn't completely replaced umbilical cord blood transplants, and there are some centers that are still doing clinical trials evaluating umbilical cord blood transplants. But in general, this study showed that there was a better survival for patients who had a haplo donor compared to cord blood donor. All right, so the idea that we can't find a donor for a patient, I think, is outdated. Because of this data, I think we can find a donor for almost all patients who need to have a transplant. Impact of age on transplant outcomes. So there is this ageism that occurs in the setting of allogeneic transplantation in particular. And that's because older patients are more likely to die from transplant and have less benefit due to advanced age. And there's also issues with cost and healthcare resource utilization. So in the United States, there was a prospective trial performed where patients who were on Medicare were evaluated prospectively and to see how their transplant outcome was. And this was basically mandated through Medicare so that we could show that allogeneic transplantation is beneficial to older age patients. So the study evaluated outcomes based on age between 55 to 64, and then if you were over age 65. What they found was that there was no difference in clinical outcomes, whether patients were 55 to 64 or if they were over age 65. So on the basis of this study in the United States, Medicare does cover allogeneic transplantation for patients over age 65. In general, patients over age 65 would be receiving what we call a reduced intensity conditioning regimen, which is shown here, And you can see that that has historically been associated with a higher rate of relapse, but also a lower treatment-related mortality. So it was thought initially, and then you see this is back in 2006, that the outcomes for high-dose intensity conditioning and low-dose intensity conditioning, RIC, reduced intensity conditioning, were pretty similar. So now I'd like to switch topics and talk about the optimal timing of transplant. There have been a lot of prospective trials now evaluating transplant outcomes in patients with MDS. And they all have very similar findings and all had a very similar way of doing the trial. This was a prospective donor selection study that basically said if you have high-risk MDS or intermediate-risk MDS and you had a donor, you received or you were planned to undergo a transplant. But if you didn't have a donor, then you received basically hypomethylating therapy. And that's generally going to be azacitidine or decitabine. So it wasn't randomized per se, but what it did say is that if you've got a matched donor, you had a transplant, and if you didn't, you received hypomethylating therapy. And what they found is that the survival was better for patients who had a matched donor compared to patients without. But the survival didn't start differentiating until at least 2 years after the transplant. And this tells me, at least to myself, that this is somewhat informative about who should be selected for a transplant. So the idea that you're going to offer an allogeneic transplant in someone whose expected survival would be less than 2 years, probably not a good idea. So you really want healthy people who don't have a lot of comorbidities, because otherwise they would die before they would see the potential survival benefit. Most of these studies are what we call intent to treat analysis, which means that patients may not have received the transplant. And indeed, in this study, there were 31 patients who didn't receive the transplant, primarily due to uncontrolled disease. So it is important to try to get the disease under control before you do the transplant, particularly if you're going to give a patient what we call a reduced intensity conditioning regimen. But as you'll see in all of these studies, and they're all very similar, I'm going to show you 3 studies, that there was a survival benefit when patients received transplant compared to patients who did not. This is called the Vidasa Allo study. It was done through the European Bone Marrow Transplant Registry. And again, this basically said if you had a matched donor, you underwent stem cell transplant. But if you didn't have a matched donor, you were treated with, in this case, azacitidine. All patients received 4 to 6 cycles of azacitidine before the transplant. And then if they had a donor, they went to transplant. And if they didn't have a donor, they continued the Vidasa. So what do we see here? Again, the survival curves don't start separating until after 2 years, whereas there is a plateau effect for patients who received a transplant. There's no plateau effect for patients who received azacitidine. So there's continued mortality in the azacitidine arm. So this again shows a benefit with allogeneic transplantation for patients who have a donor. These patients also received what we call a reduced intensity conditioning transplant. This is also a very similar study. This was done primarily in the US through the BMT-CTN. Very similar design, but it basically said if you had higher risk MDS and you had a donor, you received transplant. So in black, you see the donor arm. Whereas if you didn't have a donor, you received hypomethylating therapy. And in yellow, you can see the no donor arm. So I have very similar findings. And the findings are that it's better to have a donor than to not have a donor. And the survival curves start differentiating at about at least after 1 year in this study. So again, you do see a later survival benefit. There is an increased treatment-related mortality upfront with stem cell transplant. This study looked at different types of subgroups, and what they found is that whether you were over age 65 or less than age 65, there was still a benefit with having a donor. But in regards to disease risk, the real benefit of having a donor was for patients in the higher disease risk categories compared to patients with lower risk disease categories. So we tend to offer allogeneic transplantation for patients with more advanced disease. There is another group that I think it's important to talk about stem cell transplant and the fact that they should receive it if possible. And that group is patients who have failed hypomethylating therapy. Now, this is not a prospective trial. It's what we call a retrospective study. So it's when you look in the past. But what they found is that if patients fail treatment with azacitidine, the patients who received a transplant had the best outcome. Now, I will admit that there is some selection bias that is present here. What is selection bias? That's when patients are selected to receive a treatment. And the fact that they're selected for it means that they're probably a better risk group. And we know that patients who are selected for transplant after failing azacitidine are likely younger and are likely in better health. And that perhaps this is the reason why they had a better survival, and not necessarily the intervention itself. But besides this potential selection bias, I will say this is the best data that we have. And I will say that patients who fail azacitidine have a very short survival. So it is important to consider transplant. Now, this data set was from patients with high-risk MDS, but it's also true for patients with low-risk MDS. So whether you have low-risk MDS or high-risk MDS, there's a better survival for patients who undergo transplantation. All right, so shifting gears again, and now we're going to talk about the role of pre-transplant therapy. So if patients are going to receive a reduced intensity conditioning transplant, that means that they're not going to get a very high dose of chemotherapy or radiation before their transplant. And we have found that if you take that patient directly to transplant, they typically have a very high relapse rate. So at least in our center, it's important that patients be in remission for transplant. But if you look at patients in total, so not just those patients that are getting low intensity types of transplants, but also the patients who are getting high intensity transplants, there's not a lot of data showing that you have to give some type of induction chemotherapy or hypomethylating therapy before transplant. So this is a retrospective comparison that looked at untreated patients versus patients who received induction chemotherapy. And this is before transplant, and there was no difference in outcomes. Even in patients who had a remission after the induction chemotherapy, they appeared to have similar outcomes to untreated patients. This is just one retrospective study. There are other retrospective studies that have been done that do show a benefit in getting into remission. And this is a study looking at, these are actually 3 different studies looking at hypomethylating therapy versus induction chemotherapy. And what I can say is that the available evidence indicates that giving hypomethylating therapy versus induction chemotherapy yields equivalent outcomes after transplant. So this is an area of research interest, and it would be good to have a prospective trial evaluating this. And we have almost completed a prospective randomized study at our center evaluating this. We have about 3 more patients to enroll into this study to try to see, is giving hypomethylating therapy or induction chemotherapy even beneficial before a transplant? And if it is, which one is better? All right, now moving along, I want to speak to you about the role of conditioning intensity. So I mentioned to you that in general, older patients or patients who are unhealthy receive what we call RIC regimens. And it's not so important to get into the weeds of this. I just want to send you kind of the overall idea of what this is about. But patients who are younger or patients who are in very good health tend to receive higher intensity regimens. So there was this clinical question, is it important to give higher intensity regimens? Maybe we're just making patients really sick with no benefit. And is there really a benefit in regards to overall survival? So there have been a lot of clinical trials, actually 3, trying to answer this question, where patients were randomized to either receive what's called a reduced intensity conditioning regimen or a high dose myeloablative conditioning regimen. And what this study found is that the overall survival, and this is through the BMT CTN, so primarily in the US, was better with myeloablative conditioning compared to reduced intensity conditioning. And this is longer term follow-up. Now, this included both AML and MDS patients, and mostly this was AML patients. There were very few MDS patients in this study. And the reason why the high dose intensity conditioning was better was because of a much lower rate of relapse in patients who received high dose intensity conditioning. I should have mentioned that in order to be eligible for this trial, you had to be in remission at the time of transplant. And here you see the relapse rates. The relapse rates were much higher with reduced intensity conditioning. The treatment-related mortality was also lower with reduced intensity conditioning, But because of these very high relapse rates, the reduced intensity conditioning had a lower overall survival. And if you look at the causes of death, it did differ between what we call reduced intensity conditioning and high dose intensity conditioning. With reduced intensity conditioning, the major cause of death was relapse. With high dose intensity conditioning, the major cause of death was graft versus host disease. That's where the donor cells attack your own body. We did a study, a sub-study within this, to look to see if having any evidence of disease affects this. And now, we didn't have at the time the study was originally done, but now we have ways to identify very low levels of disease. And that's through something called NGS. That stands for Next Generation Sequencing Analysis. Basically, we can see if patients have any level of disease, even at a very low level. And so this is trying to answer the question, well, let's go beyond just remission. And I should say that remission historically has been identified as having less than 5% bone marrow myeloblast and good blood counts. So it doesn't get into the very detailed, is there any evidence of disease? But if you have no evidence of disease, which is shown here in the blue solid line, and then here in the green solid line, there is still a little bit higher rate of relapse with the reduced intensity conditioning. But then if you went to the overall survival, it was actually similar. So this study would indicate that perhaps there is not a benefit in giving high doses of conditioning regimens in patients who have absolutely no evidence of disease. And this was true regardless of what was the underlying type of disease. And I wanted to specifically point out TP53. So TP53 is a bad mutation that patients with MDS can have with historically high rates of relapse. But even in patients who had TP53, there was still a benefit in giving myeloablative conditioning compared to reduced intensity conditioning. So if you have some level of disease, regardless of what it might be, that tends to favor giving high dose intensity conditioning. We also did what's called a retrospective comparative analysis, looking at the different types of reduced intensity conditioning regimen. This is a study through the CIBMTR. There's a different type of reduced intensity conditioning regimen called fludarabine and melphalan. And most studies, this is just one, have shown lower rates of relapse if you give fludarabine melphalan. So if a patient cannot receive a high dose intensity conditioning regimen, and then you have to give a fludarabine melphalan regimen, it's probably better to give, and you have to give a RIC regimen, it's probably better to give a fludarabine melphalan based regimen. So this is my conclusion slide. I want to thank you for your attention. I'll just go through quickly what we have found. If you need an alternative donor, haploidentical transplantation is a very effective way for using alternative donor. Age alone is not a contraindication for transplant. When should patients be considered for transplant? If they have intermediate 2 or high risk MDS, but you should probably delay for lower intermediate 1 risk. And also if they fail hypomethylating therapy. Reduced intensity conditioning regimens do have lower toxicity, but this is at the expense of higher rates of relapse. And if a patient does need to receive a reduced intensity conditioning regimen, fludarabine melphalan, based on retrospective studies, have shown improved relapse-free survival. And I want to thank everyone for their attention, and I look forward to our question and answer session. Thank you very much.
Thank you, Drs. Leitch and Scott and Cindy, for your wonderful presentations. And thank you all for joining us today. For those who haven't sent in your questions, please start submitting your questions in the question box found on the bottom menu bar. And for those who want to revisit this recorded webinar, a viewing link will be sent to all registrants and will be available on the MDS Foundation website for on-demand viewing within 10 business days. Okay, let's proceed to the live Q&A. And this question goes out to either Drs. Scott or Leitch, or if you both want to answer, that's fine. Our first question is from Renee, and she wants to know, are there any alternative treatments or research studies for a patient with high-risk MDS 1 year post-transplant with significant graft versus host disease. The patient is on steroids, ECP twice a week, Jakafi and tacrolimus, and they have relapsed.
Well, I'll say that's a very difficult clinical situation that this particular patient is in. I will say that internally, we don't have any clinical trials for this individual. There may be other clinical trials at other centers, and I'll, have Dr. Leitch respond. But we do have clinical trials for relapse post-transplant, but they're generally earlier, like less than a year. And almost all of our clinical trials do require that patients not have active GVHD at the time of enrollment. And that's because of potential adverse events that could be worse once you start any type of therapeutic intervention. So I'm sorry to say that at least internally at the Fred Hutch, we don't have any clinical trials that this patient would be eligible for.
Thank you,
Yeah,
Dr.
I'll just echo that. We don't do transplant at our center, but at the Vancouver Center where transplant is done, I'm not aware of any clinical trials that would be appropriate in this situation.
Thank you, Dr. Leitch. The next question is from Larry, diagnosed in May with MDS with ring sideroblasts. His red blood cells and hemoglobin have been low for 5 to 6 years. His hemoglobin level is currently at 9.7. He was told by his hematologist that prescription vitamin B6, 100 milligram twice a day, might increase his blood counts. His current oncologist at Carmonas Comprehensive Cancer Center says that vitamin B6 won't have any effect on his red blood cell counts. He stopped taking it over 2 months ago. Do you have any opinion regarding vitamin B6?
Sure, I can answer that. I'm not aware of any evidence that vitamin B6 will improve the blood counts, but it's certainly not going to hurt him. B vitamins are water soluble, so if you take more than your body needs, it's just excreted in the urine. This is not the situation with some of the other vitamins. Vitamins A, D, E, and K are fat soluble. So if you take too much of them, they can accumulate in the tissues, most often the liver, and can cause significant toxicity there. But vitamin B is not going to hurt him.
Thank you, Dr. Leitch. The next question comes from Tahira. Would you recommend transplant? Would it be beneficial for someone who is intermediate 1?
In general, my answer to that question would be no. Most of these prospective genetic assignment trials, which I mentioned, showed benefit for patients with more advanced disease, like intermediate 2 and high-risk disease. But there are some exceptions. So, for example, if a patient was platelet transfusion dependent and had severe thrombocytopenia, that would be a potential indication for transplant, even in patients with lower risk disease. Another exception would be if they had severe neutropenia with recurrent infections and weren't responding to available therapeutic options. That would be another potential indication for transplant. And another group are patients with high-risk mutations. So this is something that, will likely change in the future. But right now, our available prognostic mechanisms haven't really incorporated mutational testing. We all expect that will change in the future. And there are certain high-risk mutations which have shown inferior outcomes for patients with MDS and a higher risk of progression to AML. Mutations like TP53, for instance, mutations like ASXL1, for instance. TP53 is usually associated with a complex karyotype, although not always. And so there's not a lot of lower intermediate 1 risk patients with P53, but there's an interesting subset of P53 mutation patients, and that's the del5q. So occasionally patients with del5q can have a mutated P53. And in my opinion anyway, and some retrospective studies have shown this, those patients have a worse outcomes. So you might consider transplanting that. But in general, the answer to the question is no, I would not, with the exception of severe neutropenia, severe thrombocytopenia, and high-risk mutational issues.
Thank you, Dr. Scott, for your thorough answer. The next question is from a patient on a clinical trial to eliminate transfusion dependence. Their ferritin level has risen to 4,700, and their MDS specialist wants to wait and see if they become transfusion independent before moving on to a chelating agent. And their question is, should I move to a chelating agent now or wait until the study ends?
Yeah, so that's a great question. I guess it really depends on how far into the study they are and what the time frame is for the study medication inducing transfusion independence or even reducing transfusion requirements. Certainly, iron chelation therapy has its limitations. These medications have side effects, which often limit the dose that can be given to a patient. So in situations where we do induce transfusion independence and have a hemoglobin level that supports this, one way to reduce iron overload would be just to do phlebotomy. However, I do think that it depends also on the transferrin saturation. So it would be interesting to know what the transferrin saturation is. Even a low dose of chelator can take the edge off the non-transferrin bound iron, which confers at least some of the toxicity of iron overload. So I think that it's a good question without really a simple answer, but those are some of the points that we deal with.
Thank you, Dr. Leitch. The next question is from Isaac. For international patients that are outside of the US, which would be a good way to get a genetic test so we can get a better idea, a more updated diagnosis? All we have been able to get in Mexico has been cytogenetics, but not the full gene test. Any information is greatly appreciated.
I think that in most countries that have, socially supported medicine, such as in Canada, we have access to something or we don't. My best guess about getting a genetic test, if it's not really available in your country, is going somewhere where you would pay for that test. Presumably that could be done in the US. That's obviously difficult right now because of difficulties crossing borders because of the infectious pandemic, but might be helpful information in the future, depending on what the person's particular clinical circumstances are and also their financial circumstances.
Thank you, Dr. Leitch.
Bart, do you have an idea what a molecular profile would cost in the US?
No, I'm sorry to say. One of the benefits that I have in working in a major academic center is kind of like this ivory tower. So there's, a real disconnect. Unfortunately, I will say that's a weakness that I have, and I fully admit that. But there's a disconnect between cost of therapeutic interventions and myself because I have a finance team that works on that side of things. So I really don't know how much it costs. We do a myeloid gene panel. It's a PCR-based assay, so we don't do full whole genome sequencing. Other centers do full whole genome sequencing, but our myeloid gene panel, I would think, would cost less because it's PCR-based without whole genome sequencing. But I'm sorry, I really don't know the details of the cost.
Yeah, I also don't know because it's socially supported. So I will find out after this webinar.
Thank you both. The next question comes from Jennifer. Her question is, when do I consider transplant with gradually decreasing marrow function? She has low risk refractory anemia with ring sideroblasts and has been on all medical treatments, including azacitidine, years ago. She was diagnosed 10 years ago. She has less than 5% marrow blasts, and she is able to stay stable on 2 units of blood every 2 weeks. But she is now leukopenic and thrombocytopenic, and a slightly increased with a slightly increased transfusion need.
So I don't really want to answer questions about a specific patient, but what I can say in general, without getting into a specific patient, is kind of what I said in the talk, which is that whether you have low risk disease or high risk disease, if you fail hypomethylating therapy, you do have a shorter survival compared to patients who have not failed hypomethylating therapy. And I'll also say that developing worsening cytopenias is generally associated with a worse outcome in patients with MDS. So if this were a person in the United States that I was following, we would consider that intervention. If I do have a patient who's has worsening cytopenias, maybe they had anemia to begin with, and now they're developing worsening thrombocytopenia and worsening neutropenia, that would be kind of a message to me to say, maybe I need to reassess what their disease state is. So I would say we would need to repeat a bone marrow aspiration and biopsy. We would do the karyotype again. And then, at least at our center, and again, I don't want to say that this should widely be done because it's still kind of more of a controversial topic, but at least in our center, we would do some type of assay for mutational analysis. And if we did find that this patient had evidence of disease progression, either by karyotypic abnormalities or by new mutational analysis, or if they were platelet transfusion dependent, or if they had severe neutropenias complicated by infectious issues, that would be a reason to say maybe we should consider transplant. And it would be a discussion that you have with the patient to find out if that's something that they want to do. Because as I said, it's not without toxicity. And as I indicated in my talk, the benefit for transplant is not immediate, it's delayed. Generally, there's not a survival benefit that's seen until at least 2 years after transplant.
Thank you, Dr. Scott. The next question comes from Renee, and she wants to know if you were aware of any genetic relationship between MDS and childhood infant leukemia. Her mother was diagnosed with MDS, and then Renee's daughter was diagnosed with infant leukemia, and she's enrolled in the TINI, I'm sorry, I don't know how to pronounce it, study, all within the same year. Her daughter is MLL negative and did not have Philadelphia chromosome. She had one genetic abnormality, which was picked up as part of the TINI study, but this is not thought to be related to leukemia.
That's a very interesting question. For the majority of MDS patients, there is not a familial predisposition. However, there are, predisposing syndromes that have been identified that were actually discussed in yesterday's scientific program. I unfortunately don't know a lot about them. I think really probably it's the pediatric hematologists who are more in sync with this because they do deal with these myeloid disorders in people who develop them at a younger age. But I wonder if that is something that Renee's family's doctors might want to look into a little bit.
Thank you, Dr. Leitch. The next question is from another low-risk patient, 75 years old, transfusion dependent every 2 weeks, otherwise in good health, had no response for 6 months to azacitidine. And they want to know if they should consider stem cell transplant, and if so, which level of intensity?
Well, the second part of the question is easier to answer, which is that would definitely be a patient who should not receive a high intensity treatment. That would be a low intensity treatment. The first part of the question is more difficult to answer, but honestly, even though I said age alone is not a contraindication for allogeneic transplantation, age 75 is somewhere where that would be really pushing it. And I would say that in general, people age 75 or older should not receive transplant, and there may be rare exceptions to that. It would be a discussion that I would have with the patient in the United States, but even in that data set, that Medicare data set that I presented, almost all of those people were less than age 75. So the data showing similar outcomes between patients less than age 65 and over age 65 is really clustered with patients who are between the ages of 65 to 70. So, in most clinical circumstances, it would be difficult to recommend an intervention with allogeneic transplantation for someone at the age of 75.
Thank you. The next question comes from Rosilius, and I'm sorry if I'm not pronouncing your name correctly. He has 5% blasts. He wants to know, is that high risk? And is he in remission? And he's African American and wants to know, should he consider bone marrow transplantation?
So I think that the risk status depends not only on the blast count, but on other factors that are enumerated in risk scores, such as the IPSS and the IPSS-R. So I think bone marrow blasts alone are not sufficient to determine risk. I can say that I do have a number of patients who I thought would be higher risk because their blasts were 5, 6, 7%, who actually remained stable for longer periods of time because their other risk factors did not put them into a high risk category. But certainly someone with 5% blasts is probably someone I would follow more closely than someone with 2% blasts. I'm not sure that really answers the question.
Just a word about, more than a word, sorry. A couple of sentences about race and allogeneic transplantation. One's race should not be considered when you're looking at the role of allogeneic transplantation. So we don't say that being of African American descent or anything like that precludes you from proceeding to transplant, but it does play a role in donor selection. And there are overrepresentation of people of Caucasian descent in most registries in the United States and in Canada and other major academic places such as Western Europe. So for that reason, it is frequently difficult to find a matched sibling donor and matched unrelated donor for people who are not of Caucasian descent. And that's really where we employ alternative donor options such as cord blood and haplo options. So I did mention in my talk about how haplo donor options are coming along, and that is a potentially good option, particularly of people who are not of Caucasian descent. So I just want to say that race is not a contraindication for transplant. That should be clear, but it does affect donor choice because the currently available unrelated donors are generally overrepresented of Caucasian descent. So a message to all of the people who are listening to this, we really need to try to improve our donor registries of people who are not of Caucasian descent.
Thank you, Dr. Scott. That's an important issue right now with health disparities. So thank you for that. The next question is SRSF2 combined with TET2 mutation considered high risk?
I'm not clear on that, and I'm not sure if it's that I'm not clear on that or if it's because it's not clear. They're both splicing factor mutations, so the combination.
Yeah, I agree. We really don't know.
Yeah. Biologically, on a cellular level, they shouldn't be really additive to each other because they both affect the same pathway, but I don't think we know that clinically.
Thank you both. The next question is from Gordon, and it's directed specifically for Dr. Scott. He wants to know what options are there for a patient post mud transplant, which is a match with an unrelated donor that has failed at 10 months with no graft versus host disease. A second transplant has been ruled out. He's doing a series of DLIs presently.
Okay, so as I understand it, the question is, a person has relapsed at 10 months post-transplant and is currently receiving DLI. And what are the potential treatment options? And doesn't have GVHD. Well, so I can tell you what we would do at our center. If it's a low level of relapse, we would give DLI. I would also recommend that this patient receive hypomethylating therapy. So we do give that in concert with DLI. There's some evidence that it could potentially improve graft versus leukemia effect, but that's what we would do here. We do have several clinical trials. So if the patient had an HLA-A02 phenotype, then we do have a T-cell receptor chimerism study that can augment a donor GVL effect that the patient would potentially be eligible for. But yeah, I would either give hypomethylating therapy with DLI, or I would enroll them into this T-cell chimerism study at our center.
Thank you, Dr. Scott. The next question is from Suzanne. She's 66 years old, diagnosed in 2011. She's now severely neutropenic. Her white blood cell count is at 1.6, and she is also thrombocytopenic in the range of 25 to 40. Her ANC is 0.8, and her hemoglobin level is normal. She was in the magrolimab and Vidasa trial, but nothing's changed.
I mean, that's a little bit of a tricky situation, and I think that really, well, first of all, it depends on her risk scores, but she's also already received a hypomethylating agent. But in terms of the neutropenia, I'd be more interested in whether a patient is having clinical infections, in which case one could entertain the possibility of either prophylactic antibiotics or GCSF injections, which I don't personally really favor unless we're forced to use them because of the theoretical risk of stimulating the leukemic clone. In terms of the thrombocytopenia, similarly, it really depends on whether there's clinical bleeding or not. And I think that there was an entire session done by Dr. Santini yesterday dealing with thrombocytopenia in the setting of MDS. Certainly in some centers, they are using thrombopoiesis stimulating agents for thrombocytopenia in MDS, usually in lower risk patients. But that's not something that is readily available in Canada, and I can't really comment on other countries.
Thank you, Dr. Leitch. Suzanne has an additional question added to her first one. Although she failed, she had 6 cycles of magrolimab and Vidasa and failed. She has a perfect match, which is good news, and she's scheduled for a bone marrow transplant in 3 weeks at an NCI center. She knew nothing about a higher intensity versus reduced intensity chemo. She sees her doctor on Monday and wants to know what questions she should be asking.
I mean, I think probably your doctor will, give her the information that she would otherwise question them on. The appointment on Monday is likely to discuss the details of the transplant.
Thank you, Dr. Leitch. The next question is from Phil. He was diagnosed with high-risk MDS in 2019. He's currently on Vidasa and venetoclax therapy for 20 cycles, and currently he's in full remission, and he has been for several months. Should he consider transplant, and what should be his next step of action? And he's 72 years old, he added.
Right. I think that if I were this individual, I would have a discussion with my physician and just bring up this potential intervention if they haven't discussed it already. It's very difficult for us as people who haven't seen any of you to make specific recommendations. So I don't want to fall into that trap because I think that would honestly do you a disservice. But it is a normal process that when a physician who is a hematologist oncologist and sees patients with MDS assesses their overall health and suitability for stem cell transplant. So I don't want to really get into the weeds of that, but there may have been an assessment of comorbidities or other health-related factors or even socioeconomic issues where a decision was made, perhaps transplant isn't in the best interest of a given individual. But I always think it's a good discussion that a patient have with their physician so that they're fully informed. Hey, what about transplant? We really haven't talked about that. And maybe the physician has a very good reason why that process has not occurred. So I don't really want to get into any situation where I might second guess or, give advice that would lead a patient down a pathway that would ultimately not be in their best interest. But I do think open discussion with a physician should always be encouraged.
Thank you, Dr. Scott. The next question comes from Derek. He is 79 years old, has been on azacitidine for 6 months, which he completed, and then 5 months on Inqovi. His counts unfortunately crashed. His ANC is at 0, and his hemoglobin fell into high risk. There's been no change with his platelets, but he wants to know where he should go from here.
I think that, it would be interesting to know whether it was after Inqovi that he had a crash in his counts, because it does seem to be more myelosuppressive than azacitidine, at least in some people. But I think that with significant change in counts, that might warrant, a reassessment of where he is at, and probably another bone marrow biopsy is in order.
Thank you, Dr. Leitch. The next question is, would you perform a second transplant if the relapse occurred in less than a year?
Well, it's not a yes or no question, but I think that is a consideration. So I'll rephrase the question as the following. Does the timing of relapse after allogeneic transplant inform the decision as to whether or not a second transplant should be performed? And yes. So in general, for patients who have late relapses, so let's say, 5 years later, 6 years later, in that situation, the message that I receive from that clinical situation is that the patient had a robust GVL effect following the infusion of those donor cells, but lost it through tolerance induction of the donor cells. So basically what can happen is that the GVL effect weakens over time. That's a natural process. And in that clinical situation where you have late relapses, that's really where you consider the role of DLI from the same donor, which can augment the donor allograft effect. So if you have later relapses, I tend to favor giving DLI with hypomethylating therapy. If you have very early relapses, in general less than a year, then I tend to favor, in the appropriate circumstances, so we're generally talking about younger patients who have good comorbidities, I tend to favor a second allograft if the relapse is earlier, like less than a year, for instance.
Thank you. The next question is, do patients have input on their transplant if they are younger and know they will develop acute myeloid leukemia?
I'm sorry, I didn't track that one. Can you ask it again?
Sure. This patient wants to know, do they have input on their transplant if they are younger and know they will develop into AML?
Okay, I'm going to try to interpret this a little bit. I'm thinking the question is, if I'm a very young patient and I have low risk MDS, should I consider allogeneic transplant just because I'm very young? I'm thinking that's what the question is. Well, that's a good question. And the truth is, I don't know. But what I will say is that the data showing a benefit for allogeneic transplantation, those 3 prospective studies that I mentioned, were really focused on patients with higher risk disease. I'll also say that allogeneic transplantation has a treatment-related mortality now, even in the best of circumstances, with high-dose intensity conditioning of about 12 to 15% in the first year. So that means there's a risk of death of 12 to 15% in the first year. In addition, even in those patients with stem cell transplant who are cured, there's long-term comorbidities. Infertility, for instance, is a big issue, particularly in younger patients. They may develop chronic graft versus host disease and require prolonged steroid therapy. And then there's a risk for secondary cancers. So in general, my recommendation to even younger patients who have lower risk disease is a watch and wait approach. So that doesn't mean that we're saying no transplant for you ever. What that means is we're saying no transplant for you now. And the question that I get immediately after that is, what if I get too old to get a transplant? And my response to that is, congratulations, hallelujah, you did it. That is a positive thing. So it doesn't mean that that's a bad thing, that you've gotten too old to be eligible for a transplant. That's fantastic.
Thank you, Dr. Scott. The next question is, if one has a genetic indicator for MDS, how does it manifest post-transplant? Meaning, is it an indicator that MDS will return after a transplant?
That's a tough one. So if I'm going to try to rephrase the question here and make sure I've got it right. If a patient has a genetic inherited MDS, are they at higher risk of relapse after transplant? There's no evidence that that alone is the case. If the question is, I still have a mutational finding, a genetic mutational finding after transplant, meaning what we now call minimal residual disease after transplant, does that mean that I'm at higher risk of full relapse? Well, probably yes, but definitively no. That's a very good question, and I'm sorry that I can't give you a more detailed answer than that. In general, our preference is after an allogeneic transplant that there be absolutely no evidence of disease. But these genetic markers, they're so interesting because some of them honestly may not be directly disease associated. So it's hard to know that if the presence of the genetic marker alone is actually meaningful. And I'm sorry, I wish I could give you more information than that, but really you're just getting to the limits of what we currently know.
Thank you, Dr. Scott. I don't know if you can weigh in a little bit more. For a patient who has a TP53 mutation, can you weigh in on success rates on transplant?
Yes. So, just to contrast that with the previous question, TP53 is really thought to be disease related. That's a bad one, and you don't want to have it. And it's typically associated with a very short survival. And it is true that even with transplant, there's a high risk of relapse. And often many of my colleagues have used that as an argument to say that patients with TP53 should not go to transplant. But I would also say that no intervention is very successful, at least to date, for patients with P53. And to my knowledge, allogeneic transplantation is the only intervention that has shown any type of plateau effect. Granted, it's at 20%, so it's not that great. But I think that we should still try an all of the above approach for patients who have mutated P53, who are younger and who are in good health. So I would definitely advocate that a patient who has mutated P53, MDS, or AML go into any available clinical trials. And we also, do clinical trials in transplant there. We have them too. So we're investigating new conditioning intensity regimens. We're investigating new maintenance strategies. So I would say an all of the above approach for the right patient who is young and healthy with P53 should include allogeneic transplant with some type of investigative approach, either conditioning intensity or maintenance therapy post.
Thank you, Dr. Scott. Great answer. The next question is from Jennifer. It's a two-part question. She wants to know if Jade New has contributed to her gradually declining marrow function.
Certainly cytopenia is secondary to Deferasirox, which is the generic name for the JNU medication, have been reported. However, so has hematologic improvement. So there's a substantial minority of patients who actually get an erythroid response, a neutrophil response, a platelet response, or all of the above. Up to 20% of patients with these iron-chelating medications. So I think that, it's not a straightforward answer. And I think that the entire context of the disease really needs to be taken into account. One easier way to determine whether it's in fact the medication would be to hold it for a few weeks and see if her counts get better, or at least stay stable. If they continue to decline, then she should likely have a reassessment of where the MDS is at.
Thank you, Dr. Leitch. The second part of her question is, she had the Pfizer COVID vaccine and her counts dropped. Do you have any information? Can you weigh in on how the vaccine has been affecting your patients?
Yeah, I think we're still learning about the vaccine. Certainly, as everyone's been hearing in the news, there have been cases of severe vaccine-associated thrombocytopenia. I'm not aware that milder cases have been reported, but there are also case reports of, cold agglutinin hemolytic anemia, for example. I saw a patient with that the other day, not an MDS patient, just a regular citizen. So I think it's still a little bit of a learning curve. What I would say is what's very clear is with higher risk MDS on hypomethylating agents, contracting COVID has really very, very negative outcomes. So I think that any risks associated with the vaccine are outweighed by the risks of actually contracting COVID. The other thing that we don't really know in the setting of MDS is how effective is the COVID vaccine. Is it as protective in a patient with MDS as it in a person without MDS? I think that's not entirely known. But what I will say is that immunity to viruses is mediated largely by the lymphoid immune system, and MDS is obviously a disorder of the myeloid immune system. Having said that, the immune system is more complex than we give it credit for a lot of the time. And there is also a potential influence of the therapy that she's receiving for the MDS on the vaccine effectiveness. In British Columbia, she would be considered eligible for a booster dose of the vaccine on the basis of receiving the hypomethylating agent therapy, because the assumption is that it's not as effective as in the next patient who's not getting the hypomethylating agent therapy. So I think that it's a very interesting question, and that it is something that we are still learning about. But I do think that the vaccine is very important for, regular citizens, and particularly for people who have something that puts their health at risk.
Thank you, Dr. Leitch. Great answer. The next question is, how often does graft versus host occur post-transplant? And are there treatments or treatments on the horizon to help counter graft versus host disease?
Second question is pretty easy. Yes. So, one of the new preventive strategies that we have for the prevention of GVHD is what we call post-transplant Cytoxan. So, for example, patients who receive haploidentical, that's the half matched on day +3, day +4, receive Cytoxan, and they appear to have lower rates of GVHD. We've also done studies for matched unrelated donors giving Cytoxan on days +3, day +4 post stem cell infusion, and they also appear to have lower rates of GVHD. In the United States, ruxolitinib, otherwise known as Jakafi, was just approved for treatment of chronic GVHD, and we also have an approved label indication of ruxolitinib for the treatment of acute GVHD. So we have better prevention strategies and we have newer treatment if you do get it. So that's wonderful. In regards to what are the rates of GVHD, the first part of the question, it depends on the donor. So for matched sibling donor, the rates of acute GVHD grade 2 to 4 are approximately 40%. And then for a matched unrelated donor, the rates of grade 2 to 4 acute GVHD are approximately 60%. Most patients with acute GVHD respond to steroid therapy and do not have a mortality event from their GVHD. So I just want to emphasize that so that it's not as if getting acute GVHD leads to your immediate death. We do have effective treatments for it.
Thank you, Dr. Scott. We're winding down. It's like we're just a little shy of 10 minutes. So if you have any more questions, please use your chat function. The next question is post-transplant. Can you explain what the next steps are in terms of care for the patient and caregiver to follow?
Yes, but in general, rather than offering specific details, because obviously that's complicated and it really depends on what's going on with an individual patient, whether they have chronic GVHD, whether they have late onset acute GVHD, whether they have minimal residual disease post-transplant, for instance, what their donor type was. There's a lot of different things that affects what the appropriate post-transplant care should look like. But in general, how I approach these patients is that once they leave the transplant center, they would come back to my clinic. And I attend both on the transplant service and on the non-transplant teams. And I have patients who are on transplant and patients who are not on transplant. But I do weekly appointments for about the first 3 months, and then I do monthly appointments for the next 6 months. They have a 1-year follow-up with what we call our LTFU team. And at that point in time, they have a complete assessment for chronic GVHD. And then after they're done with their LTFU appointment, which would be at 1 year post, I see them about every 3 months for the next year. And then we move to about every 4 to 6 months for the next couple of years. And then at year 5, if they're doing well, I kind of say goodbye and they go into what's called our surveillance team. So that's just patients with chronic cancers. Just some important points: patients who have had an allogeneic transplant have higher rates of long-term cardiac comorbidities. So it is important that if they develop any hypertension or any issues with cholesterol, that be treated aggressively and appropriately. They have higher rates of secondary malignancy, and the most common secondary malignancy is skin cancer. So all long-term survivors of stem cell transplant should have yearly skin evaluations. There is a risk of chronic GVHD, which can persist for even up to 2 years after transplant. So that's why, I want to continue to follow them. Essentials of chronic GVHD can be varied. If they have severe chronic GVHD that affects their mouth, they can develop oral malignancies. So it's important to follow them for that. But that's what the general follow-up would look like for a post-transplant survivor.
Thank you, Dr. Scott. The next question comes from an AML patient who is a candidate for a transplant but does not have a family member or a friend available to care for them post-transplant. Would it be an option to have a paid caregiver live with them post-transplant?
So I can't answer for every center, and that's really a center-specific question. But yes, at our center, we do allow for caregivers to be paid. So we have had that situation occur.
Thank you, Dr. Scott. The next question is, we only have time, unfortunately, for one more question. What is the ideal donor age limit?
Mm-hmm. Interesting.
I was laughing there because that's a matter of debate now. So I'm going to ask the question in a different way, and I'll try to be as fast as possible. But is it better to go with a older matched sibling donor or a younger matched unrelated donor? That is a great question. And we're doing a randomized clinical trial to answer that question through the BMT CTN. So stay tuned. But donor age is important. So one of the reasons why donor age is important is because as you get older, your bone marrow functions less well. So for older matched SIB donors, let's say, you may have issues with engraftment. They themselves may have some stem cell disorder. Maybe they have, what we call ICUS or CCUS, clonal cytopenias of undetermined significance, or maybe they have a mutational abnormality. We really don't know what the implication of that is. So there may be a higher risk of secondary malignancies in using older donors. But all of these are questions that are appropriate. Stay tuned. And once we get the data from this randomized trial, I'll be able to answer your question more definitively. What I can tell you right now is that we don't have an upper age limit for matched sibling donors. So we don't say that because you have a sibling who matches you that happens to be older, we're not going to use them. But we are interested in doing this clinical trial. So if that situation occurred, and once this trial is open, we'll be able to randomize patients to either receive an older matched SIB donor or to go with a younger matched unrelated donor. If you go to bethematch.org, which I kind of answered on one of the chats, that's the donor website in the US. We do have an upper age limit for matched unrelated donors. So there is an upper age limit in that situation.
Thank you. Unfortunately, that's all the time that we have for questions. Thank you, Drs. Leitch and Scott and Cindy, for participating and your time and effort that went into preparing for this webinar. It was a great talk and a very thorough overview of the disease landscape and emerging treatments. And thank you all for attending today and for your great questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. And if you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 10 business days. On behalf of the MDS Foundation, thank you so much for joining us. This concludes today's program.